Good afternoon, everybody, and welcome. We'll give a few minutes here for bringing everybody in. I'll just keep an eye on the participants, and when it looks like it's plateauing, we'll go ahead and get started. Okay, looks like we have a plateau, and others I'm sure will join as we go on, but let's go ahead and get started. We have a number of people scheduled to give some updates who will have a lot more specific information than I have, so I'm not going to spend a lot of time talking. This is now, I believe it's our 14th COVID town hall. And unfortunately, if we end up following the rest of the country, it certainly won't be our last, although we'll be giving you some local updates as we go on. So with that, let me start with Dr. Vora, because I know he has a lot of things on his plate and we have him with us. So why don't we go ahead and Race, do you want to talk a little bit about what's going on in the county?
Sure. Hi, everyone. Thank you. I always appreciate the chance to share what we've been up to from the health department side. So as everyone is probably aware, we probably we did cross the 30,000 mark. So now we have 30,471 cases registered here in Fresno County, including 430 fatalities. So we have a fatality rate of about 1 to 2%, somewhere between 1 to 2%, closer to 1.5. Currently, our hospitalizations are hovering right at 100 across the county. So at all 7 of the general acute care hospitals, we total up all of the hospitalizations. This morning, they're 96. Over the weekend, they were right at 100. I'm sure Dr. Thomas and some of my other colleagues will explain what's going on at our local CRMC site. In terms of the testing, we've got more resources than we have demand, which is actually raising kind of a problem. So if there's one kind of takeaway that I want to share with everyone is please get yourself tested if you're in public service, and please advise all of the essential workers and other at-risk personnel to also get tested. And then obviously if people are symptomatic, they should be getting tested. As I think I shared last time we did this town hall, we've actually mandated that all primary care doctors and ambulatory care clinics offer COVID testing. And they've complied. So your doctor should be able to test you for COVID. And we wanted to get ready for flu season because we know that that's right around the corner, and that people will get URIs and other respiratory illnesses. And we want our doctors and medical clinics to be ready to check for COVID at the same time that they check for influenza. So those are some of the kind of key takeaways from, I think, this last couple of weeks. We're just teetering on the border between red and purple zone. And the reason that that's important is because purple zone means that we have to kind of lock down everything indoors and really make people meet outdoors. And I think that that's just a great idea anyway. So if you're choosing to dine out, if you're choosing to go to your church, to have gatherings, etc., just choose to do it outdoors. That's the safest way to do it. Whether we're in red or purple, that's really the safest way to bring people together right now. If we go into purple, then we will have to actually enforce that indoor dining and indoor gym operation and things like that are shut down. But we don't want to go there. It's just good practice to just be aware that this is a virus that just loves the indoors and loves congregated settings. So that's something to keep in mind, especially as the fall season comes up and we get ready for Halloween and then Thanksgiving and then Christmas. You know, we do need to think about doing things differently this year. And we know that gathering indoors is a high risk activity. So we're going to be crafting a lot of guidance related to how things can be done, but that people can do it safely.
Thanks, Ray. So one of the things that we internally were having a conversation about last week is what do we advise our trainees, our staff, and so on about holiday season coming up and what they should or shouldn't do. So what kind of guidance is coming out of public health for that?
Yeah, so good question. I mean, we're trying to craft guidance that covers all scenarios, but that's almost a laughable prospect because different people celebrate these festivals in different ways. Some people will fly across the country to go see their family, while other people choose to stay at home. And there's all manner of different ways that people choose to gather and eat together and celebrate trick or treating, et cetera. There's de los Muertos. And all of these are done differently. So it's hard to craft guidance. I think what we can do is just tell people, well, these are the ways that you can stay safe. And that means wearing a mask when you're out of your household, keeping your 6 foot of distance at all times, and then choosing to do as much outdoors as you can, especially if you're going to be eating, that's a higher risk activity. So that's kind of how we're approaching it. Beyond that, right now, California is a relatively cool spot compared to the rest of the country because we're hearing about hot spots happening in the Midwest, in the South, maybe back on the East Coast as well. By the time Thanksgiving rolls around, things might be different. I mean, this just changes week to week and month to month, and we may be a new hotspot at the same time that other places are kind of cooling down. So we get questions about, can I travel outside of the state? Can other people travel from other parts of the country to California? And then do they need to quarantine? I think it just depends week to week. I think, in general, whenever you travel, it's a good idea to try to quarantine if you have the resources to do that. But we know that, quarantining for 14 days when you're away from home is not feasible. So that's why we rely on these other layers of protection to help protect the population, even if they are going to choose to travel.
Great, thanks, Race.
Thank
So
you.
let's segue now to Jeff Thomas to talk a little bit about the situation locally with the CMC.
So I think the best way to approach this is as we approach our CCG meeting every morning, starting off with our prevalence. As you know, we were up over 200, almost 220 patients within our system. Fortunately, that number began to fall in August and continued to fall down to a level that we knew would not be zero, but we were hoping it would be a little lower. In addition to that, as part of our registry or our recording of patients, we were encouraged to put patients back in our totals that actually had met all conventional recovery from COVID, but they were still hospitalized for a COVID-related illness. In other words, if you came in with COVID and clotted your superior mesenteric artery, ended up with bowel complications in the ICU, you might be 40 days past your initial diagnosis, but we're still recording those. So we're going to have a baseline of patients now with COVID complications that will be within our totals. So our first time positivity rate as a system is around 2.5%, got down below 2, and then it jumped back up to about 6 or 7. Now we're back down again. So hopefully we will continue to stay low there. I think overall our hospitalization and death rate kind of reflects what's happening in the county and state numbers. It just is delayed by a little bit as we get that data in. As far as our PPE goes, we're doing much better with what we have. Unfortunately, the supply chain, one of the textiles or the actual pieces that goes into the production of PPE, gowns, masks, and such, is a chemical or a substance that's in short supply. So it is impacting some of those supply chains. And another area that has been concerning has been the gloves, and it's not the sterile gloves for the operating room, but the actual blue gloves we use for everyday protection. So our supply chain is working very hard to, keep those channels open. From a laboratory standpoint, I think we're at 13,000 test kits right now, which is great. We still struggle a little bit on who we test and how often we test them. We're trying to be realistic about that. And our lab group is investigating the availability of some molecular or PCR rapid tests that are available. Unfortunately, the main holder of this technology is Abbott. They gave all of their technology, first of all, to government agencies. And if you're not a primary client of theirs, it's pretty difficult to break into their supply chain. We have a meeting this afternoon with their leadership to try to see if we can procure some of the rapid molecular testing, because that would certainly revolutionize how we're able to do things. Right now, the only rapid testing that's available, unfortunately, are the antigen tests, which, as you all know, sensitivity and specificity of those is leaves something to be desired. Our supply chain, as far as pharmacy goes, we get a weekly report. I think that we're doing pretty good in anticipating problems. Early on, it was remdesivir, and way back when it was hydroxychloroquine, but we have a pretty active pharmacy group that looks into where we need to secure medications and keep those supply chains going. So other than that, I'll leave it up to questions. I think our main concerns right now, number one, is the flu vaccine. We're trying to get that get everybody vaccinated. So there really is no excuse not to get vaccinated these days. In addition, we do have a group that's looking into potential COVID vaccine when that becomes available, and how we allocate that, because we anticipate initially, at least, it will be a scarce resource, but we're already looking into that. And Dr. Libke is working very closely with us to try to best navigate rapid testing and testing types, whether it be pharyngeal or mid-turbinate or anterior nasal, which we can incorporate into our hospital practices.
Okay, thanks, Jeff. So let's move then to the specifics. Dr. Jane, do you want to talk a little bit about what the status is of COVID cases in the ICU and where you stand?
Yeah, absolutely. Yeah, I'll keep it brief, but in general, the ICU numbers have been pretty manageable, especially given that we have maintained the additional resources of the third team and the night coverage in place. Quantitatively, I mean, we have been about, this morning was 28 patients in the ICU, which is a busy ICU, but it's pretty manageable with the additional resource. We have gone up to 50 plus during the peak of the COVID. At the time of the peak, the proportion of COVID cases we had in the ICU would hover from, it started 25 to 50%, and it went up, peaked at maybe 75 to 90% of the ICU was COVID at a time. And then it dropped again. Now we are below 20-25% of the ICU is filled with COVID patients, and hopefully we can keep it that way. The numbers within California seem encouraging, but we haven't hit the flu again. As we all know, the surge in Europe, and we just heard from Dr. Vora about our numbers. But we did have the record high numbers in US recently. Nothing as dramatic in California so far. But in general, it does seem like California always lags a little, and with Thanksgiving coming in, not sure who's going to bring in what from outside California. So we'll keep our fingers crossed this winter and through the flu season. The only challenge I do see upcoming, not in the immediate future, but down the road, is due to the GME cuts in fellowship positions, which will definitely affect how we staff our ICU mid next year. So.
Okay, thanks, Vipul. And then we can transition to Dr. El-Masri and talk a little bit about the research on COVID-19, and maybe if you have an opportunity to talk a little bit about what our ECMO, where do we stand in terms of our ECMO experience, since you're one of the 3 people that runs that program too, or 4, I guess now.
Yes, we are 4 now, and we have very active ECMO program. Currently we decannulated someone in the last 2 weeks, so who was on ECMO for more than 3 weeks. So a young lady who's 25 years old, we actually thought she will never get off ECMO, to the point we were considering transferring her to UCSF main campus for acute lung transplant, but luckily she made it, and our staff actually provided a baby shower for her inside the hospital. We still have actively 1 ECMO patient, and in total, we have, depending on how we count it, 13 or 14, and our mortality rate is slightly better than, well, actually comparable to the national average. ECMO, COVID ECMO, according to ELSO, has mortality rate of 38%, but please bear in mind that also at the beginning discouraged from using ECMO for COVID. So there was big selection bias. We anticipate that survival will be around 60%, comparable to that of ECMO for ARDS. So we have only 1 patient now, and he is anticipated to survive. I will go over the current clinical trial here at UCSF Fresno, and I will divide it by different groups to make it easier in case if you have a patient who might be eligible and to, sorry. So I will start actually with the most active trial. We have a Blue Coral trial. This is a prospective trial, however, is non-interventional. We collect data, biological, and this is very, very important to actually understand the disease activity. This is run through Pedal Network, and it is nationwide. Out of 1,500 patients about to be enrolled, we only did about 100. 16 of these in the UCSF Fresno. I think the last time I checked, we are probably the busiest enrollers in this trial, simply because we don't have many others that are actively enrolling at this time. Now, Act 3, which is sponsored by NIH and NIAID, is about to start probably this week. It is open label remdesivir. The trial itself is blinded, but the remdesivir arm is open because now it's considered standard. Some patients will receive interferon beta 1A, and some patients will receive placebo. This is to be provided sub-Q 4 injections every other day. The UCSF main campus is participating in this trial, but we are actually a separate site, so we had to do separate application and do a reliance agreement with a centralized IRB separate from UCSF for this trial. We also were recently approved for APL-9, which is a trial that uses anti-C3 to ameliorate the inflammatory system. This is a phase 1 trial, and it is anticipated to enroll about 60 patients. 30 of them will receive placebo, and we anticipate to enroll somewhere between 10 and 15 patients in this center. Now, Active 3, which is a trial that combines, it's the phase 2-3 combined together. This is the trial that I will probably go into more details because it has been in the media. We were active and it got paused. The pause wasn't of any incidents. The trial, because it is jumping between phase 2 and 3 together, had within the protocol safety measures. So although we are looking at 14 and 28 days outcome, however, there was a safety trigger to hold the enrollment if there was significant difference within day 5 of enrollment. So that criteria was met about a week ago, about 10 days ago, and the trial was paused because of that. Sometimes the difference is actually to the benefit of enrollment arm, to the active study arm. This is monoclonal antibody, very similar to what the president received when he was in Walter Reed. We did use Eli Lilly drug. We paused the trial and we informed the 2 patients that were enrolled here and we continue to follow them. The DSMB, the Data Safety Monitoring Board, is meeting today, and we are anticipating a decision to continue or suspend the trial later this week. We have also a trial that is about to start in November using what now being called more medicinal cells. It's adipose-derived allogeneic stem cells. It has very promising results from other centers outside of the US. This company called Personalized Stem Cell in San Diego was approached by the government agency, and they wanted them to run a trial. This is supported by FDA partially, and we anticipate to enroll about 20 patients. Dr. Fayed is actually about to start a trial for brexanolone. This is an already known drug used for sedation, but also it has anti-inflammatory effect. This trial is anticipated to start also in November. Now, Active One, we are not sure if we are starting this one as part of UCSF because of limited resources, but we are actually in the process of doing the regulatory paperwork. Active 4 is combining remdesivir and anticoagulation in 3 arms, and there are 2 parts to this. One inpatient that we will be part of, but also there is an outpatient arm that our colleague Dr. Bukhari from Hematology Oncology is trying to enroll. We also are looking at this new component by Janssen. This is part of Johnson & Johnson. Also, it is comparing this sirolimus in combination with, comparing to the standard of care. Now, in the pipeline, there is also another or other set of monoclonal antibodies in case Active 3 continue to be held. EDESA trial also is done by Dr. Fayed here, and it is about to enroll in November and December. It is the efficacy of this compound EB05 versus standard of care in adult hospitalized with COVID-19. Now, SHERP trial is mostly outpatient, and Dr. Fayed is doing this observational trial, and it is part of UCSF whole system. Dr. Brian Shinnock is doing the RAMIC trial. It's ramipril for outpatient or early inpatient admission with COVID-19. This is to bank on the ACE2 receptors and to see if blocking these receptors will alter the course of the disease. Now, also we are part of testing the accuracy of point of care, and many faculty members are involved in this. Dr. Pardia is also presenting a trial to the IRB later next week. This is part of Stanford, and looking at antiretroviral effect for outpatient for mild asymptomatic disease. This trial includes the disulfiram, and it is outpatient also trial. And as you can see, the theme here, we're trying to move also to outpatient arena because now we think we are close to solving outpatient follow-up. We did the immune biomarkers. Now, let me jump to the completed trial. Those are trials that were closed. We were part of the expanded access phase 3 program through Gilead. We enrolled 26 patients and we closed the database. Dr. Rahmati was the one who ran the Mayo Clinic convalescent plasma protocol. Both of those concluded once the medication became, or the plasma became available. Red Coral was retrospective analysis, but it included database analysis. We enrolled 10 patients in this study, and it's part of Peril Network. An ORCID trial was the trial that also stopped the hydroxychloroquine. It was hydroxychloroquine versus placebo, and was stopped early due to the lack of efficacy. I also failed to put here the COLD trial, which was liver disease and COVID, that Dr. Marina Reutman ran, and there are at least the 3 trials, 3 studies, observational studies run by our trainees, whether it's fellows or residents, including vitamin D, hemoglobin A1C, and coagulopathy in COVID patient. I will stop here and I will take question with the others.
Great, and an immense amount of work that you guys have been doing. I just saw on one of my news feeds today that there was a retrospective look at the use of low-dose aspirin in COVID patients. Do you have any insight into that study?
So the COVID active 4, which uses apixaban prophylactic dose versus apixaban regular dose, fully anticoagulation dose, has a 3rd arm with aspirin. So people also looking back again into aspirin as a potential benefit, because we still don't fully understand the coagulopathy within COVID. Many people suggested that coagulopathy goes along with inflammation, and many of us have reasons to believe that the dexamethasone improved mortality by actually reducing coagulopathy or reducing vascularity. So this is yet to be seen.
Okay, thanks. All right, Kenny, Dr. Bond, you want to talk a little bit about how things are going with the COVID Equity Project and the mobile HEAL units?
Sure. Just a quick update from a UME standpoint is that we still continue to have occasional exposures of medical students and symptoms once a week or so. Fortunately, when we contact trace, we have not yet had a single transfer of any positive COVID or students picking it up in the clinical setting. So just to clarify, that's good news. And it seems to me that most of the exposures aren't true exposures, as most people are masked and doing their job. So thank you to Jeff Thomas, and hopefully everyone is behaving themselves. Quick update, and continues to do so. Quick update from Mobile Heal. We continue to increase our numbers. We are testing approximately 200 patients a day. We are running generally 2 sites every single day now. Both are a static site at Firm as well as a different mobile site, if not 2. We're at the Mexican consulate this morning. I was there this morning, very cold for the first time, but raining ash down on us. Despite our testing numbers going up, our actual positivity rate has actually fallen. So that's good news. 2 weeks, last week when I updated, we had a positivity rate over 17% in our group, and now our positivity rate in the past week was 12.8%. So still significantly higher than what the county is reporting, and some of that is related to our population base, as well as the fact that we contact trace and bring other positives and their related like I said, we don't find one positive, we find a family of positives almost always when we find them. So, but the good news is our rates, despite increasing testing, our rates are starting to fall now, which is good. Hopefully we continue to trend in that direction. We are of course giving out flu shots and doing point of care and PCRs at all our sites now. So we're still staffing up and not fully staffed, but we are trying our best to really ramp up. We'll be doing our homeless outreach through Poverello House starting tomorrow. So we've been doing different groups, and we'll start our homeless outreach tomorrow. So I'm very excited about that. Last update from a research side is that we actually just got approval for an NIH grant-backed study as a multi-center site to do experimental point of care COVID testing compared to PCR. So we'll be experimenting both the emergency use FDA approved ones as well as non-FDA approved ones. We're still in the early phase where I haven't decided which arms and which ones we'll be trialing, but we'll be a community site enrolling patients that are not in the hospital setting, but out in the community, and comparing potentially novel or not FDA approved testing, point of care COVID testing compared to PCR. And I'm happy to take questions about that, though we haven't gotten the details on which arms we'll be in.
And we do have IRB approval now to retrospectively look back at what our experience has been with the point of care platform that you've been using against PCR, correct?
That is correct. We have IRB approval, and we'll start working on that very shortly here. And we're using currently the BD Veritor system for the antigen testing is what we've done. And we have about 3,000, and we test on everybody, so pretty much outside of a few exceptions. So we have about 3,000 tests and controls to compare to. So we got it. But unfortunately, Epic is just getting installed next week. So we're still on this very high-tech paper system. So analysis is a little bit difficult right now.
Okay, thanks, Kenny. Lori, you want to talk about implications to GME?
So right now we're in a lull, which is great. Obviously, just like everybody has mentioned, we are concerned about the winter months and what that's going to look like and how that's going to impact our educational programs and trying to keep the educational mission and the service mission balanced so that we make sure that our residents get the educational experiences that they need. We did have a slight glitch in terms of masks earlier in the past few weeks with CRMC, but we have come to a good conclusion, I think, with that. The problem is that many of our trainees were used to getting their surgical masks as they came in during the screening process, and that was never the purpose of the screening center. It was never their purpose to provide masks. So they had stopped doing that, which was not a problem for our residents or trainees who go to a place. For example, our emergency medicine residents who go to the emergency department, or our ICU fellows who go to the ICU, they always know where to go to get masks. But for many of our ward teams who aren't necessarily on the same floor every single day and don't necessarily have a contact with who to get masks from, it was creating some confusion and some delay and difficulty in getting masks. So just at the end of last week, we came up with what I think is a great plan that really should just make getting a surgical mask when you come into work part of the workflow. No matter what floor you're on, you should be able to go to the clinical coordinator's office and get a mask. So waiting for feedback from the trainees on how that's going, but I think it's a good plan moving forward that hopefully will streamline the process and not create confusion, especially if we do go into our next surge. Obviously we want everything to be moving as smoothly as possible.
Great, thanks, Lori. And Tiffany, you want to give us maybe an update on not only our experience with the influenza vaccine that's been brought up by a couple of the speakers this morning, but also about any issues around positivity rates among our residents and fellows?
Sure, I'll touch on the positivity rates first. So right now we actually haven't had any positive rates since the beginning of September. And I don't note that I have any residents or fellows out right now. I'm not aware of any faculty and actually not aware of any staff. So it's a good day today. And then as far as for the flu shots, I know it has been kind of it's a mega task this year. Everybody wants proof of them. I know Dr. Weichenthal sent out an email this morning to program directors. I think we're now down to 14 that I don't have, 14 residents or fellows that I do not have proof for. And residents and fellows cannot work at any of our sites starting November 1st if there isn't proof within the system. So please definitely send that in as soon as possible so we can get that taken care of. And then as far as, we're still encouraging faculty to get it taken care of. I know CCFMG would also like proof. We're just trying to streamline all three institutions, CRMC, UCSF, and CCFMG, so that we all have the same information about flu shots. I think you're mute, Dr. Peterson.
And just to clarify, while the hospital is strongly encouraging vaccinations, they're not preventing people from coming to work on November 1st. The policy for UCSF is you do not go to work after November 1st if you haven't demonstrated to us either a medical excuse for not having a vaccination or that you've had the vaccination. So I think that's pretty good. We're down to only maybe 5% non-compliance, and we've still got the next 5 days to get that done. So hopefully come Saturday, we'll have 100% compliance. So with that, any questions or chat that have come up? Tiffany?
Yes, so the question I have is, will there be a badge sign that you have received flu vaccine, either for UCSF or CRMC? CRMC apparently still does not have that. I'm not quite sure, because it's my understanding that CRMC has the little badge buddy. I think, is Dr. Peterson showing it? Yes, so that can be picked up at Employee Health, second floor, East Medical Plaza, the building that houses the gym. Oh, they're purple badge, not blue. They look blue. But yes, that is the badge buddy that can be used within the hospital, and then UCSF.
Yeah, and UCSF will also give you a little sticker that you can put on your badge if you want. So.
Yeah, and with that sticker, I think I'm housing those at my desk at work. So if you really want your sticker, we'll have to arrange something.
Okay.
So Dr. Peterson, I've had the experience of getting into some conversations with different staff, and I think as leaders, academic leaders, I think that a lot of people look up to residents, faculty, fellows. The conversation will arise of why should I get a vaccine? What makes this year different? Besides, in the past, if I refused the vaccine, I had to wear a mask. Now I have to wear a mask anyways. So what does it matter? I think it's important that you take a minute to explain to people, last year, I think we had more than a couple dozen patients that by virtue of infection prevention were infected with flu in the hospital, either from staff that were sick or other patients. And the numbers that we had were not necessarily considered acceptable. So it is a good thing to do, regardless of the mask wearing. It still is, an important aspect of the care that we provide.
Absolutely. This is belts and suspenders at a time when you really don't want your pants falling down. So I think that, while the mask and washing your hands clearly has a benefit, adding the vaccination on top of that is just additive, if not geometrically increasing your protection. And yes, I think that, one of the messages that we've tried to impart to the residents and fellows is this really is an issue about protecting your patients as much as it is protecting yourself. So, I think that, we have an influenza vaccine. Yes, we don't know what the efficacy is, but it's certainly more than zero. It's a fairly low risk vaccination. And the benefit will be to the patients, to your colleagues, and to yourself. So I just think, in setting the standards for the American public, I think that healthcare providers should take a lead in doing that, and you take a lead by demonstrating that that's what you do. I don't know if any of the others on the Zoom call want to make comments about that, but I think that it's a pretty indefensible position now to say, I just don't feel like it.
And I do have a follow-up question that came through that I'm not sure we can actually answer right here, but especially for staff members who are asking to decline, if they're still able to work. And I think at this point, I would refer to the manager or Monica Meza to kind of go into specifics. You can of course still work, you just can't step onto campus. And I think that UCSF is talking about making that until June 1st. So, that's something to consider, especially if you need to get on campus. So for those UCSF Fresno staff members, let's talk to Monica Meza about if you've declined and need to step on campus.
Yeah, and understand that for the UCSF employed personnel, whether they be trainees or staff, this is a mandate coming down from the office of the UC Office of the President. It was initially came out of President Napolitano, and then that has been now reemphasized by the new president, Michael Drake. So we are all operating under that mandate, and it says You do not come on to UCSF facilities without either a medical reason not to have the vaccination or evidence that you've been vaccinated. So it's not a local decision. Okay, so they are sick. Okay, so Carolyn Hankey also entered into the chat a reminder to everybody that even if you've had your vaccination, even if you're wearing your mask, if you have any symptoms consistent with COVID, do not come to work. Okay.
Thank you. Now the next question is remdesivir considered standard of care?
Yeah, do you want to take that?
Yes, yes, it is. And I think whoever is asking this question is alluding to a recent WHO trial that was called Solidarity Trial. And I have been on a lot of conference calls even before FDA issued final approval as a standard of care. And the problem with that trial that raised concern showed potentially no benefit. It was open label. It was prospective, randomized, but it was open label. So here we're asking length of stay from population that is going to receive 5 days course. So you could not discharge these people before they finish the 5 days course because it was open label. So according to all experts in the field, the other study, whether it's ACT or the study that was recently published in New England Journal of Medicine, prompt the efficacy, and FDA apparently after about a week or 10 days of analysis took this position and issued the approval. So as far as I can tell, without certain contraindications such as liver or kidney failure, remdesivir is standard of care.
Are the antibody tests, if you had COVID last year, accurate?
So I'll take a shot at this, but then maybe ask Iad to weigh in on this. So, you know, the presence or absence of antibodies are, quote, accurate, but the question is whether those antibodies are neutralizing antibodies. So, and I think that that's been part of what has driven the multiple monoclonal antibody mixes where you have antibodies which are particularly effective as neutralizing antibody that you then ramp up in a monoclonal sort of way and then deliver those, as opposed to antibodies that simply demonstrate that you've had the infection in the past but may not predict what your immunity would be. And then it's important for everybody to understand that most viral illnesses are actually handled by your T cell population, not your B cell antibodies. And while you can test for that, there isn't a lot of testing for that that's done. Yeah, do you want to amplify on that?
And most, when people talk about antibodies, most of the time they are talking about the antibody to S protein. It's one of 28 different antibodies that is being actively studied. Probably we have also hundreds of others that being researched at early phases. The problem, I think the only use for these antibodies is just to confirm previous exposure. We are all now dealing with these nagging cases. Someone looks like COVID, they are like post-COVID syndrome, but never confirmed COVID. Tested sometimes 4 or 5 times, but whether it's the CT scan or the constellation of symptoms, and sometimes the other families who have been sick, and actually currently I have at least one patient in the ICU now with what looks like post-COVID syndrome, which we could never confirm COVID in spite of being tested 3 times. So I think it will help with the epidemiology if it comes to the point to look for herd immunity and predict the outcome but for one patient, I don't think it's useful as we speak. It's not confirmed to predict anything aside from being previously exposed.
I don't have any current questions at this time.
Okay.
I'd just like to follow up on what Lori said about the PPE. We did get some education out to our floor supervisors. Originally when there was a run on the banks with masks and whatnot, they resorted to kind of locking it up in the supervisor's office. We're hopefully leaning more towards kind of a PPE cart that's more available for everybody to access. Everybody needs to understand that the masks provided at the check-in station are just those unrated masks that get you to your unit where you should put the appropriate surgical mask on. They were never to distribute surgical masks at those stations. Our goal is that everybody should be protected. If there is an instance where residents, fellows, or faculty are within the hospital and feel that they do not have access, we need to know about that. People are free to email or call me immediately, because what that will require is a little re-education on the part of the hospital staff or supervisor. One thing that did come up though is they need to be consistent with the policies that have been put forward by the command center. For instance, the goggles that are allocated are in rather short supply, and the policy is to clean those with the purple wipes and reuse them. And we had a few unit supervisors saying that people were coming in and discarding goggles and asking for a new pair because the last pair they used was on a different floor or a different area. So they just asked that the folks are utilizing the PPE in accordance with the current policies, and that is for reprocessing of eye protection.
Thank you. And this was a comment that was made. I don't know if it needs any follow-up discussion, but A/B testing most likely only for population health, not individual patient management.
Yeah, I think that just amplifies what the ad said, that it's not very useful in the individual patient other than to demonstrate prior infection.
No other questions at this time.
Okay, well, once again, I appreciate the panel. I always learn something from everybody on the panel. And as I pointed out in the presentation at Mini Med last week, this is part of what makes being in medicine interesting and exciting, because you never know when around the corner is a brand new disease waiting to jump out at you. And then you get to spend many hours learning with everybody else about how you manage the disease, how it behaves, and so on. So exciting times. I hope that everybody is taking some time for themselves. I think this whole issue of COVID fatigue is particularly acute among healthcare providers. I think we need to stay focused on the fact that people need to take some time for themselves and some activities for themselves, so that they're well rested and ready to come back and do their jobs in a difficult environment sometimes. So thanks to everybody, and we'll see you, some of you, next week, and we'll plan another town hall probably in November, bring you up to date with what's going on. So thanks.
Thank you.
Thank you.